We are very privileged this morning to have Dr. Olt with us. She's a respected community physician, and she is also the founder of Jolt. And so she's going to speak to us today on stigma and bias and substance abuse disorder. And we want to welcome her and thank her for spending the morning with us. So, good morning. Thank you.
Good morning, everyone. Thanks for being here early. Hopefully it's interesting enough that you don't fall asleep. Try and keep everybody awake. I just wanted to start by telling you just a little bit about why I do this work. Some of you were here when it happened, and but some of the younger nurses were not. In 2012, my son Josh died of a heroin overdose. He was 16 years old. We did not know he was using drugs, and certainly never imagined that he would use heroin. He used alone in our home and overdosed there. He was still alive when the ambulance got there, but died on the way to the hospital, and they never got him back. So in a way, stigma and shame played a role in his death because he never asked for help. We didn't know he was using, we didn't know he was struggling. He didn't want friends to know, so he used alone, which we all know is heroin's a very dangerous drug to use alone. There was no naloxone in the community, no harm reduction, nothing. And actually the first ambulance that got to my house did not have naloxone at that time. None of the basic volunteer ambulances carried naloxone. So when he died, of course it was a total shock and just unimaginable tragedy for our family. And speaking more to stigma, also, our story was front page news. It was on every TV news channel, the front page of Journal Star, local physicians, 16-year-old Dunlap High School kid dies of a heroin overdose. And of course we know there were other people dying from heroin overdose, but it was a big deal because of who I was. So at that time I had to make a decision for my life and for speaking my son's story. Do I sit in a corner and cry and hide from what happened, or do I do something? And I just got so mad at other people telling what happened. That's when I started doing interviews with media. Because I'm like, oh no, I'm going to tell my son's story. You're not. And so that kind of started the whole path of trying to make change, trying to understand. So I've spent the last 9 years educating myself on substance use disorder, figuring out what I could do within our community and nationwide to make changes so that we could stop people from dying. And that's why I'm here today, because I guess that's all the work I've done for the past 9 years. I am the executive director of Jolt Foundation. Jolt initially just started as a naloxone distribution program because that did not exist here. So I put every kit together myself, went around talking to people, please help me get this out. At that time, it was within several months of Josh dying, so I'd be crying, talking to people, asking them to help. So we did that for 4 years, and then I realized that the best way to get naloxone into the hands of people who use drugs is through a syringe exchange program. And that's when Jolt Harm Reduction developed. So now we're a fully functioning syringe exchange program, so we have direct access to people who use drugs. And we know that people who use drugs are most likely to save each other because they're together. So we've done thousands of overdose reversals by peers. I'm also the executive director of a national organization, GRASP and Broken No More. GRASP stands for Grief Recovery After Substance Passing. It's a peer group where you're only allowed to be in it if you've lost someone to substance use. And the Broken No More part is a drug policy, advocacy, science-based education about drug use and all the things that are wrong in our country. So I've spoken throughout the country, other media outlets, to try and engage in drug policy reform. That's a whole other thing, but we will talk a little bit about some drug policy today. So this is a really appropriate time to talk about this. First of all, International Overdose Awareness Day is August 31st, and it's internationally recognized day, and there are many events that happen around that time. We'll be having a candlelight vigil at the riverfront on that day. But with COVID, it's been a problem for overdose. The latest statistics came out, 95,000, next slide. There were 95,309 overdose deaths in the US between January 2020 and January 21. That's a 30.9% increase over the same time period the past year. The increase is primarily caused by synthetic opioids, so fentanyl. Other factors that we believe are playing a part is isolation. People have lost their support groups, maybe people that they used with. There's been lack of access to treatment, loss of jobs and housing, and people are using alone more and dying. And we know that stigma is the key factor in influencing drug policy, laws, and access to care. So this is a really good time to try and push for changes. Next slide. This is just a graph showing the top line is deaths from synthetic opioids. Heroin's down on the bottom, one of the flat lines. So we can see where the overdose deaths are coming from. Yeah, you see, methadone is low, heroin, static. You see the big, most synthetic opioids. So that's where our deaths are coming from. Our drug supply is deadly. People who use drugs and have used them for a long time don't know what they're getting. Even in the same baggie, it may be one little corner is straight fentanyl. The next dose is heroin and fentanyl. The next dose is heroin. So even from bag to bag, people don't know what they're getting. They can't keep themselves safe because of our illicit drug supply. So it's just not safe for anyone to use at this point. The next topic is really important because I hear the terms all day, and maybe someone who introduced me even said one of the words that we don't use. So instead of addict, well, first of all, we always want to use person first wording, okay? An addict is not, they're not their disease. They are a human being. So you would say a person with a substance use disorder, a person with opiate use disorder, alcohol use disorder. They're person first. Same with alcoholic. So drug problem, drug habit, you want to say substance use disorder. And two of the terms we really don't like are drug abuse, drug abuser, substance abuse. You cannot abuse an inanimate object. And those words come with really strong negative connotations, right? When you hear abuse, you think of physical abuse or sexual abuse. They're super negative words, and we're putting this on people who use drugs, and then it becomes part of how we view them as medical professionals, as human beings, and part of how they view themselves too, which is harmful on both ends. We do not use the terms clean and dirty. Human beings are not clean or dirty. Their urines aren't clean or dirty. So instead of clean, we would say negative for substances. Instead of dirty, we would say positive for substances. So a clean drug screen, or if somebody says they're sober, we don't use those terms. They should say abstinent or not actively using. Or if they are in drug use, just say, they're actively using at this time. And this is the stuff that you'll want to document in your charts also, the language that you should be using. So as far as former reformed addict or alcoholic, you want to say person in recovery, person in remission. Remission is really kind of the most current term that we use. And this stuff, the language changes all the time. I have to try and keep up. And instead of opioid replacement or methadone, you want to say medication for opiate use disorder. Even MAT is out because that stands for medication assisted treatment. Well, the treatment is the medicine. Studies have shown there's no difference if people get counseling with buprenorphine or methadone, or if they get the medications alone, outcome is the same. So that's why we don't insist on that.
Sorry, people are messages.
So this slide was made by Urban Survivors Union. It's a group of people who advocate for themselves. They're located throughout the United States, but it's people who actively use drugs, and they try and influence policy and reform and speak out for themselves about what they need and the changes that they feel need to happen. Next. So everybody hears the term war on drugs. I'll be honest, before Josh died, I really didn't know for sure what that meant. How do you fight a drug? What does that matter? First of all, it's a failure. It does not work. The war on drugs refers to coordinated campaigns by governments over the last 50 years to enforce the prohibition of drugs, largely through the coercive suppression of production and criminalization of drug use, possession, and supply. When the United Nations came into being 60 years ago, and when President Nixon launched the US government's war on drugs 50 years ago, policymakers believed that harsh enforcement would change. So we have criminalized, we have hunted down drug suppliers, we've hunted down people who use drugs, and 50 years later, we are no better off. We are worse than ever. So it's time to rethink. Let's rethink punishment. Let's treat this as a public health issue. And many countries, the US included, were very much about punishment, not about helping people. There's a campaign that's out that's called Support, Don't Punish, because punishing is not helping anything. Next slide. Okay, so these are factors that contribute to stigma. Since using drugs and having drugs in your possession is illegal, you're automatically a criminal. So that's what many of us see when we see a person who uses drugs. Well, they're a criminal, right? They're doing something illegal. But we have to remember we've randomly picked certain substances to be illegal, right? Alcohol's legal, weed's legal mostly, cigarettes. And these are all, the choice of what's illegal is all based in politics and discrimination against certain groups of people. Opium was against the Chinese. Weed back in the day was against blacks and hippies. Cocaine, the cocaine laws have been used against blacks and Hispanics. So our drug laws have resulted in mass incarceration of black and brown people. So because they're illegal, people are driven underground. They don't ask for help. They're seen as criminals. They're shamed, and so they don't reach out for help. Only 10% of people with substance use disorder are receiving treatment in the United States. People who use drugs also don't trust institutions and doctors. Many of them have been treated terribly by medical personnel. There are criminal records that they have just for possession, not for hurting anybody, really doing nothing but using their substance. So once you have a felony, it's difficult to find jobs, housing, and education. And this just creates a cycle where you can't get a job, you can't find anywhere to live, you're on the streets, so your life's terrible, and so you continue to use drugs. Why not? It just creates this cycle. Somehow we have to find a way to break this cycle. Next slide. So we all know stigma from medical providers is real. So that's why I talked about language, so important to think about how you're speaking to someone who uses drugs. And we all need to look inward. What biases do we come to work with? Maybe you've experienced living with someone who uses drugs and it's been terrible. Your bank account's been devastated, or you've watched a sibling destroy your family. There are lots of things we experience in life that we come with to work every day. So we have to kind of look inward, try and move beyond our personal experiences about how we think about people who use drugs. And, well, most people think that, people who use drugs are criminals, and it's seen very much as a moral failing, an ethical deficiency, that they can't just stop. Why would you do that? Just quit. Well, it's not that simple. And we take care of the most heavily stigmatized group of people, which is pregnant people, right? A lot of us are moms. We can't imagine that you would be shooting heroin or meth when you're pregnant. Why on earth would you do that? Well, it's their disorder. Pregnant moms who use drugs love their children just as much as any of us do, and they reflect negatively on themselves. Do you think they don't feel terrible about what they're doing? They do. They do. I know they might not discuss that with you, just meeting you as a nurse on the floor, but they do love their children, and they do want to be better and take care of their children. They don't want to leave the hospital without their children. So we have to remember, opiate use disorder is a chronic, relapsing disorder of brain structure and function. When you're thinking about these people, it's something very difficult to overcome. And pregnancy is the absolute best time to get people into treatment because they're super motivated. They don't want their baby taken. They don't want to, be hurting their baby in the pregnancy. So it is a great opportunity to get people into treatment if that's what they want. Excellent. So just remember, the substance use disorder is brain changes that go on. These people are not morally deficient. Try and pull back those thoughts when you're caring for them, and it'll be easier to deal with some of our patients. I just want to go over a little bit about why this is so hard to get over. So we have endorphins, right? They're like kind of natural opiates in our body that we all make, and they're put there for our survival. They're the things that stimulate us to have sex, to reproduce, to eat. So they're meant for the human species to survive. Well, opiates are an exogenous endorphin, so it's coming from the outside. And so when we take opiates, it suppresses the natural endorphin system in our body and shuts it down. So when people stop using, yes, we can get them through withdrawal, that sort of thing, by medications. They can tough it out, which I don't recommend. But the long-term changes are they have a suppressed natural endorphin system. So they don't feel good. They feel like anhedonia, like hard to enjoy anything, depressed, it affects mood. And so that's why medications for opiate disorder are so important, because it'll come and fill those receptors and make the people feel, not high, of course, but just okay, just normal. And we've all seen people in withdrawal, right? It's horrible. People feel like they want to die, and it's a very strong feeling and urge to want to use again because they feel so bad. So that's why it's so important that we get medications like buprenorphine or methadone started in the hospital so that people aren't going through withdrawal. And it's absolutely necessary for pregnant people because otherwise preterm birth, miscarriage, it's super important that they're not in abject, horrible withdrawal when they're pregnant. So 2 terms that I don't like and that we all hear, you've all heard enabler, tough love. They're kind of the opposite sides. Like a parent that's an enabler, well, you let them live in your house, you give them money, You know, you should just throw them out on the street. And tough love is the opposite. Well, you're using drugs, you're out. And those people end up homeless. They're injecting in bathrooms and alleyways, and if they're women, they're subject to sexual abuse, often have to turn to prostitution to survive, to buy food, to get drugs, which they often get for free for prostitution. So this is one of my friends who's one of the leaders at the national organization, the Harm Reduction Coalition. I got into harm reduction to enable people who use drugs. I enabled them to protect themselves and their communities from HIV, hepatitis C, and overdose. I enable them to feel like they have someone to talk to, someone who cares, someone who respects them and their humanity. And I enable people who use drugs to take personal responsibility for their health and their futures. If that makes me an enabler, I'm proud to claim that term. And that's how I feel about harm reduction. So we hear the term harm reduction. I think a lot of people now kind of know what that is, but it's basically, okay, like wearing a seatbelt is harm reduction. Any kind of dangerous activity that you do and you take precautions to decrease the harm from that activity, that's harm reduction. Having your kids wear a helmet on their bike, harm reduction, wearing sunscreen. But as it applies to people who use drugs, it's a non-judgmental, non-coercive approach to reducing harms of drug and alcohol use. We don't force our feelings or our wishes onto our clients, like at Jolt. We meet them where they are. We consider any incremental change is good. If they're not ready to stop or don't want to, that's okay. But okay, how about you use a clean syringe every time to decrease getting HIV and Hep C? How about you don't use alone, or you always have naloxone around with our deadly drug supply? And most of all, we welcome them as human beings and respect their rights to live healthy lives, to obtain access to health care, to be given compassion and acceptance no matter where they're at in their drug use. And that's at the heart, for me, of harm reduction is love and compassion. They're human beings, and they already feel, many people already are not feeling super great about themselves. It really doesn't help us to try and push it down even lower. So I really believe that just love and support is huge. And that may make people care about themselves so that they want to get into treatment, want to make positive changes. And this is a hard one. It is for me, being a physician. You know, well, just get into treatment. Why, you know, we don't want you to die, but not everybody's ready. So we just have to sit with them where they are and not push our feelings or our wishes for them onto them. So this is just standard harm reduction services that are pretty much available in any syringe exchange throughout the country. And Jolt has all these services. So we do free HIV and Hep C testing, condoms, naloxone, which that's at the heart of what we do and why Jolt started. We have fentanyl test strips so people can test their drugs and see if fentanyl's present. At this point, we have to assume it is present everywhere, but still, it's for them to know. Sometimes it's like, okay, I need to go slow. I need to not use so much. Of course, syringes. We have all the supplies for drug using available. Cottons, cookers, anything people need, sterile water throughout the whole process of injecting drugs to be clean or sterile at least. We have sharps containers, so that's part of what a syringe access program is supposed to do, is get back the syringes so they're not out in homes and streets and so forth. So they get sharps containers and then they return to us and we give them more. We do have testing for all drugs on a limited basis, where if somebody doesn't know what they have at all, we can kind of test and see what it is. We do harm reduction counseling, so we actually talk to them about safe injection, keeping their sites clean. I mean, anything that is going to reduce the harm of drug use, we talk to them about. We refer to treatment, of course. Jolt refers to me or to anybody that we can get them in with in the community. We take them to appointments, including like to come to get buprenorphine or methadone. We deliver supplies. We cover like multiple counties around, so we'll drive out to Kewanee, Galesburg, Canton, anywhere in our surroundings, Tazewell, to get people there, especially during COVID, to get people their supplies. And we clean up needle litter around the neighborhood so people don't get mad at us. Next slide. So we need to talk about medication for opiate use disorder because, not surprisingly, there's actually stigma against using medications that will save your life and make you feel normal and get your children back and let you work. So the three main medications that we have are naltrexone, buprenorphine, and methadone. Naltrexone is also known as Vivitrol. It's an injection, and it's a complete opiate blocker, so Netfan. It completely blocks the receptors, so people often don't feel super great. It's kind of going back to all your receptors are blocked. And actually, there's a higher chance of overdose towards the end of the shot. As it wears off, it actually upregulates the opiate receptor, so if they use towards the end, they're actually more likely to die. So not a huge fan of it at all. Buprenorphine, of course, we see a lot of our patients on. It's a partial agonist, so that means it doesn't activate the opiate receptors in a way that patients feel high, or it just sits on the receptor so people feel okay and blocks withdrawal symptoms, blocks cravings, so that people can just get their lives back. And the beauty of buprenorphine is it's a film or a tablet, so people don't have to come in every single day like with methadone. They can get a prescription and then show back up, in a week to start, and then a month. And then like my stable patients, they come in every 3 months to get their medication. So they can get their life back. They're not tied to obtaining a drug to help them. And then methadone, of course, is a full agonist. It works just like, oxycodone, heroin. It sits on the receptors and activates them. So really no difference except it's just used as a controlled maintenance medication. So, especially in pregnancy, because of the danger we talked about, preterm birth, miscarriage, we really need to get our patients, converted over to buprenorphine or methadone, and off of heroin during pregnancy. So just kind of best practices. We don't exclude patients if they don't want treatment. We ask them. If they want to go, fine, we help them. We don't exclude patients if they're using other substances, because even say if somebody's using meth and heroin, they're still better off having the buprenorphine on board to protect them from overdose, from having to go to our terrible drug supply. Now I try and get them off, but it can be a chore sometimes. We want to offer, even if people aren't using, if they say they're just following abstinence and they're at risk, which we know from multiple years after opiate use disorder, people are at risk to relapse. And then they're especially likely to die because they're abstinent. They have no tolerance at all. So they can use once and die. And that's what, we often see. Some of the deaths in the news are people who've been abstinent. And we should start this in the hospital. When people come in overdosing, it would be fantastic if from the ER they were started on buprenorphine for a few days supply and then hooked up with a provider in the area. It's a perfect time to get people on treatment. And always give naloxone to our patients that have substance use disorder, even if they're on buprenorphine or methadone, because they still relapse on these medications. So we want naloxone in hand to all of these patients. And telehealth has been a blessing during COVID people have been able to it was kind of forbidden that you weren't supposed to do medication for opiate use disorder treatment via telehealth, but they allowed it. They changed the rules during COVID. So like I may have people that live 2 hours away that I'm able to communicate with and get them started on medications. I do still kind of like to see their face at some point, but it doesn't have to be so frequent to make it impossible for them to access care. And so low barrier, low threshold medication for opiate use disorder is the way to go. I've tried to eliminate hoops. Hoops are part of stigma, right? You have to do this and this and this, making it so difficult the patients just leave. They're like, well, no. Or you get an appointment and they just talk to you that you gotta come back in 2 weeks to get your buprenorphine. Well, guess what? A lot of people don't make it back. They die of overdose, or they're like, never mind, I'm using it again. So like when my patients come in, it's basically, we do a physical exam, a long history, I talk to them, we get an HIV and Hep C test, make sure they're a candidate for buprenorphine, and they leave with a prescription that day. And that's what's key. You can't send these people away. But our drug supply is too dangerous. These people need this medication. And they've taken the time to show up and want treatment. You have to catch them at that moment. And I do home induction versus office. Office is another thing that's kind of limiting. The patient has to be started on it, sit there in the office for 2 or 3 hours. And it makes it kind of undoable for practitioners also. So we just have them do it at home. Now pregnancy is a little bit different. If we're starting them, after viability, 2nd trimester, 3rd trimester, they probably really should go through induction in the hospital just to monitor the baby, and we're really checking on what level of withdrawal they're in when we should start the medication. So that's an exception, doing it in the hospital with pregnant people. And there's stigma actually within the treatment community. I had this group of guys that heard I was prescribing Suboxone, and they were going to a local treatment that was inpatient, and they wanted to get started on buprenorphine for when they left. So I'm like, okay, so they came in, and several of them, and when they went back, the counselors at this place actually told them, you don't need to be on this medication. It's just, why are you trading one drug for another? And we were getting phone calls like, yeah, they're nodding off during treatment. They're not nodding off on buprenorphine. They're tired and they don't sleep here, So I was just shocked that this treatment provider, when we have science, evidence, there's a 50 to 75% decrease in mortality when people use these medications, and they're telling my patients they shouldn't be on the medication. So stigma is alive everywhere, and in places really where you think it wouldn't be. So yeah, I had to make a few phone calls too. That it wasn't that nice. Okay, so other places stigma comes from is the family. Patients are afraid to tell their family that they're on a medication because lots of family members say you're just trading one drug for another. Why do you have to take methadone or buprenorphine? So it's all about education, helping them to understand the brain changes, helping the patient to know so they can tell their family. The patient often doesn't even want to admit, like their family may not know that they're using heroin again. So they're afraid if they take their buprenorphine home and somebody finds it, then they'll know about their drug use. And then there are certain cultures that are, less likely. So there's cultural factors that go along. And then just society in general makes people who use drugs feel ashamed, that it's a moral failing instead of seeing this as a health issue. And then, of course, back to us as a medical community, so hopefully we can all do a better job of helping people get into treatment. Or if they're still using, treating them as a human being worthy of our attention and care. So we want to make sure anybody on medications for opiate use disorder has naloxone, they're at risk for relapse. And this is just kind of going over some of the data. controlled trials, systematic reviews, and these are huge reviews, okay? Like tens of thousands of people studied to get this data. Methadone and buprenorphine are associated with higher retention rates, markedly reduced rates of opioid use, mortality, healthcare use, and crime, compared with patients receiving placebo, no treatment, or abstinence-based psychosocial treatment or medical detox. So the medications are very important. Next slide. So let's remember that a person who uses drugs can be anybody. I never dreamed that my child would do heroin. You know, my husband and I have been married 29 years, something like that now. We had all the kids at our house. We knew all of their friends. They were always welcome there. We thought we were doing things right. And we still had a child who died from overdose. So it can be a person from a two-parent family, a divorced family, a single mother, rich, poor, black, white, Hispanic, and any families at risk. So let's always just, you know, remember that it really can be any of us, any of our children or family members. And this is Josh. So if we can all just remember that everyone is somebody's someone, then maybe we could do, you know, a good job of taking care of our patients with substance use disorder. That's all I have. If you guys have any questions about anything I've said, I'm happy to answer anything. There's a lot of information. I'm just trying to touch on basics so we know how to think when we're seeing these patients. We could spend an hour on the whole exogenous, endogenous opioids, things like that, understanding the whole brain pathway, because it's much more complex than what I just presented. But it's a framework for how to think.